Good afternoon, everybody. Bismillah ar-Rahman ar-Rahim. Thank you, Professor Hisham, for your nice presentation to me. As usual, we are happy to be here year after year with this well-organized events with high-browed presenters. In the next few minutes, I'm going to present some synopsis about the medical oncology approach to a rather hot topic, which is neuroendocrine tumors. Neuroendocrine tumors, as you know, is not a common event. Usually, it's very rare, and we do not face such a diagnosis every day. However, we have to know some of the points about its origin to be aware about what we have in this disease entity. As we know, it arises from the neuroendocrine or neurochromaffin cells dispersed throughout the body systems. So it can affect many locations, many anatomical locations all over the body. So we are expecting to have a lot of presentations according to the site of origin, and not only due to the peculiar hormonal syndromes which might be present due to the release of a lot of neuropeptides and the catecholamines. We might have tumors with hormonal production, and in many instances we have just a tumor without any presenting hormonal manifestations. As we know, neuroendocrine tumors are not that much to be encountered in our routine daily practice. However, looking to the SEER database, when we look to the incidence of malignant diseases in general, we reached a plateau over years. However, for neuroendocrine tumors, we have a rising curve for disease starting from the year 1970-74 with 1.09 per 100,000 population to 5.5 also for 100,000 population. We have about five-fold increase in the incidence of neuroendocrine tumors over years. It could be due to a real increase in the incidence, or it might be due to better insight in diagnosis, and we have better identification of a lot of tumors that could be missed in diagnosis before that years. Also, according to the data from the American Cancer Society, neuroendocrine tumors constitute about coming the second among the most commonly tumors to affect the gastrointestinal tract. Also, when we come to disease location specific, we find that the lung, small intestine, and rectum are among the sites with rising incidence as compared to other common sites as the colon and pancreas. When we go to the PubMed or the trials published over the past 25 years, we have a sharp rise about resources concerning with neuroendocrine tumors, either in the PubMed or from the National Cancer Institute, probably because we have, as we said before, better insight into disease, and we have many options for management of advanced disease. Also, time is the gold factor in improving the survival of metastatic disease. However, we have many key issues in the management. First, how do we define the disease? We know that we have a lot of histopathological entities, many of the locations, so we have to speak in a unified algorithm of management so as to share our data together, to have published data, so to come to valid and established guidelines. Also, we have to identify patients who needs treatment in reality on our practice, because most of patients are presenting with no symptoms, although they have high tumor burden. Should we have to treat these patients or not? We have to answer this question while designing the treatment strategy. Also, we have many of the arrivals in the pharmaceuticals market tackling not the neuroendocrine tumors in particular, but the biological backgrounds, the key players playing in the backstage of disease responsible for its progression. So we have to know what's the treatment and how could we go in sequence so as to improve the outcome of disease. As we know, neuroendocrine tumors was diagnosed first in the year 1907 by the German scientist Oberndorfer, and since that time, many of the staging and the classification systems were attempted. Actually, they have no prognostic or predictive validation. There we have better identification in the year 1995, depending on the size, invasion, and the activity or the vitality of the tumor itself. And we started to have several classifications, several stages of disease, or better description, being benign or low malignant, benign or low grade malignant, or low grade malignant actually, or high grade malignant disease. And this is an example we can see here in the one as Professor Nadia definitely better covered. This is an example of the well-differentiated tumors with scattered, dispersed, immunohistochemically stained cells, the black dots. Here we have many of the mitotic figures with a lot of immunohistochemically stained disease, where we can say with confidence this is poorly differentiated tumor. And this was translated into a better way into grade 1, 2, and 3, being a malignant disease as we used. We have the mitotic figures less than 2 for tumors with low mitotic or proliferative index, Ki-67 of less than 2, grade 2, 2 to 20, and associated with Ki index or labeling index of proliferation of 3 to 20, and high grade or grade 3, more than 20 mitotic figures per 10 higher power fields, and Ki-67 index of more than 20. Again, we have the well-differentiated form. I'm talking from the clinical practice based on the European Neuroendocrine Tumor Society and WHO. We have the well-differentiated category comprising grade 1 and 2, and here they are called neuroendocrine tumors. And the poorly differentiated category, grade 3, with high number of mitotic figures, with high Ki-67 index of more than 20. And here we have two types of tumors, the neuroendocrine carcinoma of the small cell and large cell type, as Professor Nadia has just mentioned. Definitely, when we are proceeding through the grades of disease, we have compromised survival, and this is well established. And we have to know other prognostic factors that could be of value in determining the outcome of disease, not only the proliferation or the mitotic or the proliferative index, but the location of the tumor, which might facilitate its complete surgical resection, as well as how to deal with metastatic disease as if present. Also the extent of disease stage, differentiation, grade, the patient age, and performance status. All of them are going to be in harmony in defining the prognosis for each individual patient. But we should not forget that about 65% of patients with advanced neuroendocrine disease will not be alive at 5 years. Also, the diversity of the histopathologists we have, locations, we have some differentiation in TNM and the AGCC staging system in its last vision. We have the same staging for the stomach, duodenum, jejunum, ileum, colon, and rectum, but we have different staging for the appendix and pancreas. Again, we are going, when we passing through the stages of disease, we have definitely compromised survival outcome. Again, we should not forget that about 50% of patients at presentation are going to have a spreading disease beyond the primary tumor, either to the regional nodes or to distant metastatic sites. This in particular can be explained due to the vague manifestations of disease at its initial presentation. We might have some colics, distension, pain. This is usual and cannot be attributed to certain malignant disease in particular. However, as time is passing, we are going to develop metastasis, evolution of the hormonal syndrome if it's going to be present, mostly in the form of flushing and diarrhea. And at this point, we are approaching the point of death. So the estimated time from the onset of disease till diagnosis is rather long. It's about 5 to 7 years. So we should think of having such a disease if we have a long-lasting or long duration of symptoms of unexplained origin and not going to be controlled by the conventional medications. I think Professor Nadia had covered the issue well regarding what we need to know from the pathology report, so I'm going to pass it because of time. Going to the biomarkers, the immunohistochemical stains, we have to well establish the chromogranin and synaptophysin, which can aid in diagnosis and establishing that we have a neuroendocrine tumor. Others, like the neuron-specific enolase or the NCAM, could help, but not of clinical value yet now. For the circulating markers, we have the chromogranin A, which is elevated in 70 to 90% in serum among patients with metastatic NET disease. Others that could participate, the pancreatic polypeptide, the beta subunit, as well as the neuron-specific enolase, but with lower shares. The value of having elevated serum chromogranin A was validated in many of the trials. As here, we can, for patients with lower level of high level of serum chromogranin A, more than 200 units per liter, we have wide separation of curves between the lower and the higher level of chromogranin expression in serum. Also, high levels of serum chromogranin, when we are suspecting to have liver disease, it indicates heavy load of tumor burden in the liver. Also, it has a predictive value and validated in many of the trials, especially that when we have an early response after adopting whatever treatment, we have early response translated into drop of the serum chromogranin, the progression-free survival is extremely significantly different. We have a hazard ratio of 0.25. We don't see this figure usually in our daily practice, but it's here, it's very sensitive and indicates that this patient is going to entertain longer progression-free survival as compared to those who are not going to respond. The same for the neuron-specific enolase. But nothing without expenses. We have to remember that serum chromogranin A could be elevated in many of other situations. It's common situations more than the neuroendocrine tumors, as those with chronic atrophic gastritis, patients with prolonged use of proton pump inhibitors, and those with variable grades of renal insufficiency. So we should not go that this patient is going to have neuroendocrine tumor with elevated, just with elevated serum chromogranin A. We need to have the full battery of diagnosis and investigations. Going to look, definitely, Octario scan. Using Indian DTPA octariotide SPECT, this is the first choice and should be implemented whenever we have an established diagnosis or we are sure that we have a neuroendocrine tumors. For advanced disease, I think the floor is open for everything. Surgery, systemic treatment, local ablative maneuvers. Systemic treatment could be of the conventional cytotoxics or the recently introduced biologicals like everolimus and sutrinib, and we are going to cover this within a couple of minutes. For surgery, definitely it's the cornerstone for curative management, and it should be adopted for primary lesions as well as metastatic disease whenever possible. To render a patient R0 of his primary tumor or the metastatic disease, this is going to have about 5-year survival of 60% even for the metastatic patients. Also for local ablative maneuvers, we have the widely practiced like radiofrequency ablation, which is commonly practiced for many years now for disease, for metastatic disease in the liver. And it is associated with promising outcome over 5 years for certain group of patients where we can ablate totally, or even when we combine the open radiofrequency ablation with resection or debulking of the tumor, its cost and the morbidity are very low. Also, the hepatic arterial embolization, we have also improvement of the response rate as well as progression-free survival, but it's associated with more frequent complications like post-embolization syndrome, cholecystitis, and so on. For radioembolization with the yttrium-90 microspheres, here the cost is questionable as it costs about 10,000 euros per procedure. And here it should be weighed in terms of the cost benefit if we are going to implement. For chemotherapeutics, the floor was somewhat limited till the development of streptozotocin and especially when it is combined with other cytotoxics, but still we have variable response rate as well as median overall survival, and we can say with confidence that the results are not much satisfactory to the practitioners as well as to patients. Among the recently introduced agents in the management of the cytotoxics used for, to stop here? Okay.
If possible, to continue, please.
Okay. Temozolomide, we know to use it in the in gliomas and in melanomas. Also, it has a share now in neuroendocrine tumors, and it's associated with a response rate of about 70% partial response according to RECIST criteria, with a median progression-free survival of 18 months. For somatostatin analogs, which are identified in many of the neuroendocrine tumors, we have at least 5 receptors to be identified, and if we are going to block these receptors, we are going to have, we anticipate that we have blocking of the hormonal syndromes with some of the anti-proliferative effect translated in clinical practice into more than 60% symptomatic relief of the manifestations as well as tumor shrinkage in 5% of cases. And we have 2 agents now, the octreotide and bazirotide, which are similar to the somatostatin, and they are effectively blocking basically receptors 2, 3, and 5. And octreotide was tested in phase 3 trial versus placebo in patients with well-differentiated mid-gut neuroendocrine tumors associated with significant improvement in the in time to progression. And this was maintained irrespective if we have functioning or non-functioning tumor, pointing to the anti-proliferative effect of octreotide LAR with accepted, responses, if we are going here, it's about 40% response rate all in all, with safe toxicity profile. Among the factors indicating that we are going to have better results when we use octreotide LAR is to have a better hepatic tumor load of less than 10% of the volume of the liver, as well as resection of the primary. Again, the safety profile, as we said, was okay. Coming to the angiogenesis as a hallmark of malignancy, we are all oriented with what we know as a von Hippel-Lindau gene. This is responsible for tissue oxygenation. So if we have mutation of the gene, we are expecting to have hypoxia. This is coupled with excessive release of the vascular endothelial growth factor and angiogenesis. So if we are going to use the anti-angiogenic agents like bevacizumab plus octreotide LAR, which was tested in patients with neuroendocrine tumor, versus octreotide LAR plus other biologic, which is interferon, we have progression-free survival significantly improved, 96% versus 68%. Also, we are all acquainted with the mammalian target of rapamycin, a cellular protein responsible for the cellular growth, proliferation, and autophagy or programmed cell death. When we have overactivity, we have resistance to apoptosis, increased proliferation, and altered the metabolism of the cell. So, a potent mTOR inhibitor, which is everolimus, was tested in phase 3 RADIANT 3 trial against the placebo, proved to have significant improvement of the progression-free survival, again with a very nice significant hazard ratio of 0.35, not commonly seen in our daily practice. And the adverse events are usually well tolerated at a dose of 10 milligrams per day, mostly in the form of stomatitis. And now we have many of the biologics we have can be coupled with the octreotide LAR, which is rather associated with lower toxicity profile. And this was the basis for the RADIANT 2 trial, coupling everolimus plus octreotide versus placebo plus octreotide LAR. Again, we have improvement of the progression-free survival with a 0.02 significant p-value. For subgroup analysis of patients, this could be suitable for patients with better performance status, those with lung followed by other tumor locations, as well as patients who did not receive prior chemotherapy are going to fare much better. The adverse events are, as usual, we are talking about stomatitis and aseptic pneumonitis in the minority of patients. Also, sunitinib is another key player in the management of neuroendocrine tumor, being small TKI. Also, it will end with attacking the angiogenesis, and it was proved to have significant prolongation of the progression-free survival. And here is the last version of the NCCN guidelines. We can stratify our patients into 3 categories. Those with resectable disease go safely for resection for the primary and for the metastatic disease, and then the patient will be kept under follow-up till progression or metastatic events. If we have asymptomatic and low tumor burden beyond the resectability, still hold your weapons, observe your patient, and start to use treatment when you have symptomatic or significantly increased tumor burden. Here you are going to use everolimus, sunitinib, cytotoxics. All of them are accepted as first-line treatment in this order of manner. My final take-home message is that we should not consider neuroendocrine tumors as rare tumors. They are there, and you should suspect in some patients. Surgery is a cornerstone of curative management. Also, the serum biomarkers are still there to share in follow-up of patients. Tissue markers should be more highlighted. And finally, molecular targeted therapies are the hope for tomorrow, and thank you.
Thank you, Dr. Mohamed. And now we will close this session because we are short of time. There is no time for questions. And now we can have a coffee break. Thank you.